We'll bring the committee to order, and the witnesses on the first panel, please be seated. But thanks everyone for being here. I especially want to welcome some folks who will be speaking from North Carolina. And before we get started, the Personnel Subcommittee of the Senate Armed Services Committee meets this morning to receive testimony from government and civilian witnesses on traumatic brain injury, or TBI. And, gentlemen, each of you will just start from my left and go across, and you can spend up to maybe about 5 minutes on opening comments.
Well, Mr. Chairman, Ranking Member, and distinguished members of the panel, it's indeed a privilege and honor to have this opportunity to appear before you today and provide a testimony for this hearing on brain injuries in military service members. As was said, I'm a professor of neurology and founder and director of the concussion program at the Mayo Clinic in Phoenix, Arizona. I've been involved in the evaluation and management of patients with concussion for over 21 years, and I currently oversee the clinical and research concussion programs at Mayo Clinic, several of which are funded by the Department of Defense and the National Institutes of Health. I'm the chair of the American Academy of Neurology's Concussion Committee, and I co-direct their annual sports concussion conference, and I'm also the president-elect of the International Concussion Society and co-founder of concussion.org. So we'll start with what is a concussion. A concussion is often referred to as a head injury, but it's not synonymous with a head injury. It's instead an injury to the brain itself. This injury involves individual cells in the brain and the wiring that connects them. There is both a primary and a secondary injury to the brain that results in dysfunction, disruption, and likely even death of living cells and their living connections. The primary injury occurs from the direct impact of the blunt force of the rapid movement of the brain within the skull. But the secondary brain injury occurs because of an inflammatory response that occurs and the inability of stunned and sick cells to generate the energy required for their repair. These primary and secondary injuries result in a breakdown of the normal electrical and chemical communication between cells. And it's this disruption of this extensive and interconnected communication grid that affects many sites in the brain and leads to the varied symptoms, several of which you've already highlighted today, including physical, cognitive, emotional, and behavioral symptoms that have an enormous impact on the individual, a very devastating one, and actually affects the ability to function in daily life at work, at home, or in school. So why is concussion a military and a public health priority? I think concussion by any measure is a health priority. It's very common, obviously. It can lead to permanent symptoms in some and progressive neurological disease in others, and yet, as was alluded to, remains significantly underdiagnosed. For U.S. forces deployed in Afghanistan and Iraq in Operation Enduring Freedom, Operation Iraqi Freedom, and Operation New Dawn, blast exposure was the leading cause of concussion. Blast injury is results in the rapid transmission of an acoustic wave through the brain tissue. Over the last 16 years, an estimated 320,000 U.S. troops, about 1 in 5, returning from active theater, has sustained a concussion. And among those, almost half experienced symptoms consistent with post-traumatic stress or post-concussion syndrome. Therefore, not surprisingly, there's a heavy personal, family, and financial cost of these injuries to our men and women in uniform. The cost of care alone has increased from $21 million in 2003 to over $650 million in 2010. And the median health care cost for veterans with traumatic brain injury is 4 times higher than those for veterans who do not experience traumatic brain injury. Among civilians, nearly 4 million concussions occur every year, and among these, sport-related concussion has obviously received the most media and public attention. While there are several reasons for this, chief among them, I think, is the devastating long-term neurological consequences that have been demonstrated in amateur and professional athletes who participate in contact sport. And this should be of particular concern to all of us because there are over 46 million children and adolescents in the United States who participate in sport, and they, in particular, are uniquely vulnerable to the complications of concussion because of the effects of brain injury on a developing brain that hasn't fully matured. Another vulnerable population that's often not talked about is women. Approximately 20 million women experience a domestic violence-related traumatic brain injury in this country every year. A recent study by the New York State Office for the Prevention of Domestic Violence revealed that 92% of the women in domestic violence shelters were hit in the head by their partners more than once, and almost 1 in 10 were hit more than 20 times in the past year. Concussion is under-recognized, as I said, and while the reported number of concussions in this country is staggering, the actual number is much higher. It's estimated that only 1 in 6 concussions, especially in sport-related concussions, are recognized and diagnosed. And this is due to a lot of different reasons, which I'll get to. One major reason for the lack of recognition of a concussive brain injury is the lack of symptoms. Just as brain injury from silent strokes and other silent lesions that can occur in the brain, so too can silent concussions occur. And these so-called subconcussive hits have been demonstrated to be far more frequent than actual concussions themselves, especially in contact sport athletes. These subconcussive injuries are especially important because the cumulative effect of subconcussive impacts results in a loss of the brain's normal architecture and neurological and psychiatric consequences later in life. Much of the research on subconcussive hits has been performed in athletes involved in contact sports. And if you look at many of these studies, some of which I've outlined in the testimony, you will see that even in individuals who haven't experienced a concussion, there's a loss of normal brain function in those individuals, both at a youth level as well as at a collegiate and professional level. So these and other similar studies indicate that concussion is really the tip of the iceberg, while subconcussive hits represents a larger hidden danger that results in injury to the brain and lingering effects that are not being detected by current concussion assessment techniques. While the majority of individuals, as was said, experience symptom resolution from a single concussion within a week or two, post-concussion syndrome, or the persistence of symptoms beyond 4 weeks, occurs in about 10 to 20% of individuals after a single concussion. In children and adolescents, the percentage who experience persistent symptoms beyond 1 month has been shown to be at least 30%. Individuals who experience persistent symptoms may become functionally impaired or indeed permanently disabled. In addition to post-concussion syndrome, repeated concussions and subconcussive hits can lead to permanent cognitive and psychiatric impairment, a syndrome known as traumatic encephalopathy syndrome. In individuals with traumatic encephalopathy syndrome, symptoms persist for longer than 2 years and progress over time. The symptoms and signs of TES, or traumatic encephalopathy syndrome, are similar to those seen in chronic traumatic encephalopathy, or CTE. And as many of us know, CTE is a progressive degenerative brain disease that's been demonstrated to occur in individuals with a history of exposure to repeated head injuries. Unfortunately, and this is something maybe we'll get into, at this time we don't yet know how to identify people who are at risk of developing CTE, nor do we yet have a reliable method to diagnose the disease before death or to intervene with treatment that prevents or disrupts the progression of the disease. I'll end with the challenge that we as clinicians taking care of these patients face. The diagnosis, I think, of concussion is challenging even for experts. The reasons for this are several. First of all, many of the symptoms are subjective. They have to be reported by the athlete or the individual, and many times they're not. Or the symptoms, as I said, may be absent. They may have had a subconcussive hit or a silent concussion or brain injury. A lot of times the visible signs may not be present. Even for those of us who have been examining patients for over 20 years, the signs can be so subtle that they're not picked up on the routine bedside neurological examination. And finally, the detection of concussion often requires objective and quantitative tests that are not part of the routine neurological examination. Even when the diagnosis of concussion is made, the challenging of managing the patient is difficult because there are no pharmacological agents, not a single one, that has been shown to be effective in improving symptoms or interrupting that secondary injury cascade that occurs that I alluded to earlier. Another challenge for the clinician is knowing when the brain injury has stabilized. It's been well demonstrated now that the brain injury continues and is not fully recovered long after the symptoms have resolved. So we're lulled into a sense of complacency, thinking that the examination is normal, the symptoms have resolved, and so that individual is ready to return to duty or ready to return to play, and that simply is not the case in many individuals. And it's during this window of time where the brain is uniquely vulnerable to repeat injury that may result in symptoms that persist or more serious, may result in permanent injury. So determining if and when this window of vulnerability is closed is very challenging without expensive brain imaging that is not widely available, not feasible on a large-scale basis, and still not validated as a reliable clinical tool that can be used on an individual basis. So what is needed? Well, given the challenges in diagnosis, treatment, and ability to provide patients with a prognosis, I think there's an urgent need for objective, widely available, and cost-effective tests that do the following. rapidly and accurately identifies when a concussion has occurred, allowing for the removal of that individual from the activities that place them at further risk, indicate when it's safe for an individual to return to their previous activities, and this will avoid exposing an individual to a repeat and potentially devastating injury, predict who is most vulnerable to repeated concussions, and predict who is at risk of long-term symptoms and chronic neurological impairment from repeated concussions and subconcussive impacts. We also need tests that accurately diagnose traumatic encephalopathy syndrome and chronic traumatic encephalopathy so that treatments, when developed, and I'm optimistic they're coming, can prevent the progression or at least ameliorate the symptoms of these diseases. There's also, in addition to the diagnostic tests that are necessary, there's a serious need for treatments that can prevent these second injury cascades that are set in motion with that primary impact to the brain. Because I think it's these second injury cascades that can persist for days, weeks, or longer that result in the progressive brain damage that occurs and likely results in the persistence of symptoms that these individuals experience. I also think there's a need for treatments that facilitates the brain's ability to repair, adapt, and compensate for previous injury, to prevent the development of chronic neurodegenerative diseases, and to interfere with the progression of those diseases when they've already begun. Until this occurs, I think we need to implement validated examination techniques that are sensitive for the detection of concussion immediately. I am confident in the dedication and commitment of the scientists and clinicians involved in this field, several of whom are in this room, and I'm optimistic that the scientific and treatment advances will be realized for the benefit of millions of men, women, and children affected by concussion. Mr. Chairman, Ranking Member, and distinguished members of the committee, thank you again for this opportunity and for your precious time and attention.
Thank you. Dr. Devick.
Mr. Chairman, Ranking Member Gillibrand, and distinguished members of the committee, it's a high honor for me to appear before you today. I'm the CEO of King-Devick Technologies. We develop objective physical electronically transmittable tests of eyes and brain function, which are validated in peer-reviewed medical journals and are able to be administered by laypersons. Before beginning, I'd like to recognize Treg Doerson, who's right there. Treg is the son of NFL two-time Super Bowl winner Dave Doerson of the Chicago Bears and New York Giants. Dave was a friend of mine. He was a brilliant scholar athlete who graduated with honors from Notre Dame and later took his own life at 50 years old by shooting himself in the chest so that his brain could be evaluated because he was fairly certain he had chronic traumatic encephalopathy. He did indeed have an advanced case of CTE, although was diagnosed with very few concussions in his career. Treg's a highly successful businessman now, and he's also a Notre Dame athlete. His dad was drafted by the Montreal baseball franchise, too. Treg's often said if he played baseball, he'd probably be still alive today. But anyway, he's dedicated his life to doing something about the CTE, which is just a prevalent problem, and we've called to attention again this week when, with the NFL had an issue with the diagnosis on the sidelines. As far as our products are concerned, in a DoD NCAA-funded study published in November 2017, in a peer-reviewed journal, it was found that King-Devick test was shown to have the highest test-retest reliability when compared with more than a dozen other concussion tests. This article was authored by members of the CARE Consortium, the NCAA, and the Department of Defense. And in May of 2017, King-Devick Technologies was one of the group of participants ranging from the federal government representatives, private industry, professional medical research, and veterans communities invited to compete in the VA's annual Brain Trust Innovation Summit. King-Devick Technologies was selected as a winner of the 2017 Innovation Awards for its brain injury remediation and rehabilitation applications utilizing technology that allows for faster recovery from TBI and concussions as well. Because the diagnosis of MTBI concussions in service members and everyone often relies on history alone, the DoD VA clinical practice guidelines indicate that a confirmatory objective test for concussions that could be used to direct support and or predict outcomes would be desirable. And in 2016, a group of military officers who are doctors identified King-Devick test as a solution. The quote from their article was, "We recommend the King-Devick test be utilized as a supplementary screening tool in those who have suffered a concussive event. Having pre-injury King-Devick test data will allow more precise determination. Therefore, we recommend the test be included as a baseline for all warfighters prior to exposure to risk of MTBI. Having a validated, rapid, easy-to-access brain screening test can assist frontline providers in making return-to-duty decisions. And since 2011, more than 110 peer-reviewed articles have been published in elite medical journals validating these King-Devick applications. These articles describe the products as clinical biomarkers, not serum biomarkers, and other aspects of the test helped in remove from play decisions. And the effectiveness of this product is concussion detection led to its co-branding with the Mayo Clinic, the first co-branding agreement ever entered into throughout Mayo Clinic's 150-year history. The test, now known as the King-Devick test in association with Mayo Clinic, is the most validated sideline screening tool for concussions currently available. Changes in performance can easily be transmitted to inform diagnostic and related clinical service provision and guide clinical decision-making from theater to medical treatment facility. Thank you.
Thank you all. I have a question for Dr. Devick. Can you give me an idea of the cost, the timing of the test, and where these tests can be administered?
Did you say the cost?
Yep.
Oh, the cost is less than $20 per year per individual for unlimited testing. So there's very little cost involved.
And when is the test administered after somebody's experienced an injury that you're testing for?
Well,
Or is it something you do on a recurring basis to a larger population?
Well, it's the sideline application that we're partners with Mayo Clinic on is at the point of sidelines, immediately after the concussion occurs.
Is this a sort of a test that could be reliably administered in a battlefield situation?
Yes. As a matter of fact, it's, hundreds, actually thousands of teams and leagues around the world use King-Devick tests, and they do it on a noising, the NFL doesn't use it yet, but I think they'll get there. The Canadian Football League does. All of the administration can be done on the sidelines where there's noise and whatever else goes on the sidelines. So it's just a 2-minute test that checks your ability to move your eyes.
What are the other alternative tests? Give me some idea of what that I would guess they would be competing against a test that's obviously gotten a lot of attention. But what are the other? What's the landscape look like out there in terms of options?
Well, right now it's kind of a 3-legged stool for sideline testing. One is ocular motor function, which is what our test applies to, and one is balance, and then one is cognition, like who's the president, what day is it, those kind of questions. I think that when you apply all 3 of those that can be done quickly on the sideline, you get very high specificity and sensitivity. So as Dr. Miles said, ours is a tool. There's other tools that they should be combined with, but again, the whole suite of tools doesn't take long and it can be done on the sidelines.
Is there any data out there with respect to false positives? I mean, is it highly accurate? Do we sweep in that may not have suffered an injury?
Well, the false positives we aren't nearly as concerned about as false negatives.
Right.
So the specificity and the biggest meta-analysis ever done on our products they combined 15 studies together, and the sensitivity was 86% and the specificity was 90%, which is higher than anything like a pap smear or anything else, and it's done on the sidelines. It's not 100%, but it's certainly a better indication than asking the player how he feels.
Okay, and this anyone who has information on it, what research has been done this actually speaks to something I'll spend more time with the second panel, but Senator Blumenthal and I and others on the Veterans Affairs Committee are worried about PTS and TBI that may have resulted in behavioral problems that ultimately precipitated an other than honorable discharge. So what research has been done to the population who experiences a concussion or something on the spectrum of TBI, where there are measured behavioral differences in the person after that are virtually unrecoverable? They just become a part of who they are, in this case, the soldier. And anyone who has any information on that, I'd like to hear it.
Well, there's the DARPA DoD VA study just done by Dr. Shear found that with comorbidity, that is what you described, where there's a PTSD or something else in addition to a concussion, she found in this article that's pending publication that Dr. Dodick may know more about than I, that when there's comorbidity, the defect of your oculomotor test on King-Devick test lasted for years.
Or Dr. Miles?
Yeah, I would say there's actually been quite a bit of work, especially imaging work, that's been done in some of these individuals. And so what they found, first of all, is actually in the temporal lobe, which is sometimes referred to as the limbic lobe, where many of the structures in the brain are housed that govern and control emotional function, is altered. Its architecture is altered after a concussive brain injury, such that I saw a recent study indicating that the amygdala, which is part of the brain that drives the fear response, part of the brain that's responsible for impulsivity, aggressive behavior, is actually enlarged after a concussive brain injury, while other areas in the temporal lobe, such as the hippocampus, for example, which is what allows us to remember what we're being told, actually shrinks over time.
So are you able to determine a change without having a reference point, let's say an image of the brain prior to the event?
Yeah, very good question. So not exactly, but the studies that I'm talking about compared to age and sex matched or age and gender matched controls, right? Obviously, it would be ideal to have a pre-injury MRI scan on all these individuals, but it's not feasible or practical. So it ends up being compared, and it's within the 95% confidence interval of change in that individual. So there's a variety of imaging studies. There's also some molecular studies that have been done showing, an upregulation in something called the corticotropin receptor, which is measured, which is a sensitive surrogate marker of the stress response. So there are both physiological, biological, and imaging changes that occur in individuals who exhibit this impulsive aggressive behavior after a traumatic brain injury.
Very good. Thank you all. Ranking Member Gillibrand.
Thank you, Mr. Chairman. While the symptoms of TBI may appear right away, others may not be noticed for days or months after injury or until a person resumes everyday activities. In some cases, service members do not recognize or admit that they are having problems or understand the problem and how the symptoms they're experiencing impact their daily activities. Are you looking at delayed onset? Excuse me. Are you looking at delayed onset TBI in your research? And do you think it's getting enough research? And do you think there's any way we can integrate awareness of delayed onset into policies and procedures at the DoD and VA?
I alluded to the secondary injury cascades that are set in motion after the primary impact, and I think it's these inflammatory cascades that are set in motion that continue for days, weeks, or even months that are responsible for some of the delayed onset symptoms and signs that you're talking about. We and others are doing preclinical work in animal models showing what some of those changes are, because what that does, it allows us to sort of tee up high-value targets for therapy. We're also doing some imaging work following patients prospectively over time to see some of the structural and functional changes in the brain that occur well after the injury.
I mean, I've seen those images. They're remarkable.
They're startling.
We do some of it at locally, I think, at Walter Reed.
Yeah. So I think there really needs to be a public awareness campaign. We've seen the results of massive public awareness campaigns where individuals are educated about the signs and symptoms of stroke, for example, because now we have all these clot-busting therapies, and we need patients to recognize them and get into the hospital as quickly as possible. We need the same sort of public awareness campaign around concussion. As I said, 20 million women have suffered traumatic brain injury, 46 million kids exposed, are in contact sport. I mean, it's a massive public health problem. We need a public awareness campaign that matches the importance of this problem.
I agree, which is why I think if we can have the military be state of the art, we can then have a better conversation about sports and particularly kids in sports. I mean, I don't want my child playing football. It would scare the heck out of me. Even soccer scares the heck out of me. I was glad when they finally said no headers until you're at least, I think, 13 or 14. But, these are real issues. And I think if the military figures it out, then the rest of us can figure it out. And that's why it's so important. A second question, based on your expertise and research into the diagnosis and treatment of TBI in the civilian population, what do you think the military and the VA can do to improve their approaches to prevention, diagnosis, and treatment? What ways can you guys influence the civilian world?
Well, I'll start by just saying that, I can only talk about what I can control in my own center, and in that control, we've implemented what we believe is an evidence-based, objective, and quantitative neurological assessment, pre-season, I'm talking about sport athletes now, pre-season and after injury. And that's why I said earlier, I think it's really important that we at least use the tools that we have. While not perfect, they are objective, they are quantitative, and they are sensitive for detecting concussion. So I think an evidence-based approach needs to be implemented. And this field is evolving.
Yeah.
Every day new research comes out, and it's incumbent upon us on behalf of our patients to be able to adapt and evolve with the changing science.
And do you think that the military and VA's approaches to diagnosis and treatment are effective methods for preventing the potential long-term consequences of the injury?
Well, I'm not intimately familiar with the military concussion protocol, but again, I would just say that as science becomes available, I think that military physicians, civilian physicians, we all need to adapt and evolve with that.
I think that, there's new things available all the time. One of the things is the oculomotor aspect that the military hasn't used much so far, but is being used in branches of the military, and of course balance and cognition are being used. So I think that that package of three evaluating tools is what is becoming more and more the state of the art in at least in sports.
Thank
It
you.
really needs to be objective and quantitative because, I've been examining patients for over 25 years.
Yeah.
And even to this day, when an individual comes in with a concussive brain injury, I would have a hard time picking up on a bedside neurological examination deficits that I could hang my hat on and say, yes, this individual's had a brain injury. That's why I think the guesswork needs to be taken out of it. The subjectivity needs to be taken out of it. We have quantitative objective tools. We need to implement them now, and we need to continue the research and work hard to find better tools.
Thank you. Thank you, Mr. Chairman.
Senator Warren, before I recognize you, I want to thank you for your consistent participation in these subcommittee hearings. This is a very important one. I appreciate you being here.
Thank you, and I apologize for running in. I'm trying to cover another hearing at the same
I
time.
should also say there are a number of hearings
Yeah.
happening at the same time. This is a very
So-
important subject.
But this is really important, and I really do appreciate your holding this hearing, Mr. Chairman. This is critical, and I thank all of you for being here today. Since 2000, more than 370,000 service members have received a first-time diagnosis of traumatic brain injury. It is one of the most common and least understood injuries that service members experience. And thanks to the work that you and others have done, we now understand that exposure to blast pressure can result in an impact-related concussion, where the brain is damaged because it bangs around inside the skull. But we are also now coming to understand that the blast pressure wave can also cause harm by damaging the brain at the subcellular level. And while most people think of TBI as being the result of exposure to an IED explosion on the battlefield, we're now learning that it is not the only or even the most common source of blast exposure for service members. So I was very glad to get an amendment into this year's defense bill that requires the Pentagon to begin a longitudinal study of the blast exposure that our service members experience on the battlefield and when firing larger weapons during training. Can I just ask you, Dr. Dodick, can you explain why tracking blast exposure over time is essential to helping us get a handle on this problem?
Well, I think a blast exposure traumatic brain injury is in some ways different than the kind of brain injury that one might experience on a football field or on an ice hockey rink. There is an acoustic wave, as I mentioned earlier, that travels through the brain at a very high velocity that at a microstructural level damages the tissues and disrupts the connections between cells, in addition to, as you say, rattling the brain around inside of its skull. So there are multiple mechanisms of injury that I think are distinct and unique, and I know that there are some research labs in the country looking specifically at the cellular level, the injury cascades that are set in motion after an acoustic blast like that. So I do think the injury is different, and I think the work is ongoing right now to see whether or not, at the end of the day, does it really matter? Are the same cascades still set in motion? Is the initial impact injury from a blunt force to the head versus a blast injury, is that the same?
Right.
And how different are they? There's no question in my mind, as you allude to, that up until recently, we've always said concussion is a functional brain injury from which 90% of individuals recover fully. Well, that may not be the case, because even when you do an MRI scan, which is certainly more sophisticated and can see the brain at a finer detail than a CT scan, you may not see the injury until you peer at a microscopic level with special types of MRIs, and then you see these fiber tracts that are just completely disrupted, like you took a pair of scissors to them, that you don't see on a routine MRI scan. So I agree with you completely. There's a lot happening at a cellular level, at a microstructural level, that we can't pick up on routine clinical imaging. We definitely need more imaging research, and we definitely need more basic research to understand whether or not these two injuries, the blunt force versus the acoustic blast, is similar in the damage to the brain that occurs as a result of them.
Well, you know, we all know that traumatic brain injury can have devastating lifelong consequences for our service members and our veterans, and I'm grateful for the work you're doing in this area. I hope you will let us know if there is more we can do. I have a question about protective equipment, but I'm already over my time. Is that all right, Mr. Chairman? Is that all right? Thank you. Good. So I want to go to another area here. The Pentagon is at the forefront of research into equipment that protects the lives of our soldiers and sailors and airmen and Marines. For example, I am very proud of the cutting-edge research that the Natick Army Soldier Systems Center in Massachusetts is doing. Everything from improving body armor to preventing stress injuries. Natick is also at the cutting edge of helmet technology, and the research has shown that different helmet designs and shapes can change the way that blast pressure impacts the brain. But right now, most of the military helmets that we give to deploying soldiers are designed principally just to protect against bullets and other blunt injuries rather than blast injuries. So, Dr. Miles or Dr. Dodick, whoever would like to do this, what does the research tell us about the types of helmet modifications that might reduce pressure transmitted to the brain in a blast? Who would like to go?
I would say, Senator Warren, that there's no evidence to date that any technology, helmet or otherwise, has actually been able to reduce the incidence of concussion. Because as you said very early on, it's that movement of the brain within the skull. It's almost like, I make the analogy, it's like an egg. It's like a yolk inside of an egg, and you shake it, you can break the yolk, but the egg looks fine. Helmets have done a very good job at preventing skull fractures and preventing major catastrophic intracranial bleeding, for example. But there's no evidence yet they've been able to reduce the incidence of concussion.
Well, my view on this is that we owe it to our service members, anyone who is put in harm's way, to have the best possible equipment. And the best possible equipment starts with research, to figure out what works and what doesn't work. So I hope this is an area where we are doing more and trying to determine what we can do to best protect those who are in the field fighting for us. Thank you, Mr. Chairman. I appreciate again your having us.
Thank you, Senator Warren. And Senator Miles, I'm not going to ask other questions except request that our office get together, talk about the consortium, and see what we can do to try and help, because that really is a collaboration where it's not just DOD, it's private sector, everybody coming together, and I think that holistic approach is probably going to produce the best result. Thank you all for being here. We appreciate your time.
Thank you.